Hello, I'm Andrea Deyrup, and I'd like to begin by thanking the Association of Pathology Chair's program directors for inviting me to give the C. Bruce Alexander Lecture. It truly is an honor. Thank you very much. The title of my talk is But Now We See, Reviewing Race in Medicine. Now, I say I feel honored, but I have to admit I also felt surprised because I see myself predominantly as an undergraduate medical educator. I work on the Robbins textbooks. I teach at Duke School of Medicine. I don't have a very prominent role in graduate medical education at Duke. But I think you will see in the course of this lecture how the material I'm focusing on is relevant not just to UME or GME, but to all of healthcare. And what that material is has been race in medicine, specifically in the context of the pathology curriculum. We've been given talks across the country, not just to departments of pathology, but also to clinical departments, pediatrics, ophthalmology, dermatology, because this material is so important and pathologists bring a unique perspective to this. Now, you may have noticed I've used the term we. It is not the royal we. I'm referring to my colleague, Dr. Joseph Graves Jr., who's a professor at North Carolina A&T State University, just up the road in Greensboro, North Carolina. He's an evolutionary biologist, which brings a much needed perspective to this discussion, and is the author of numerous articles as well as several books looking at race. So I'd like to give you a little bit of an insight at how I got started on this pathway, and as with so many things in education, it began with a learner. So I received this email on February 11th of 2020. We were 3 weeks into a 5-month-long course, and this is the email that arrived. A student wanted to discuss the evidence related to racial disparities in blood pressure, which was that week's topic. She said that as a class, they'd received a great deal of conflicting information relating to race and health disparities. At Duke, we have a longitudinal course called Cultural Determinants of Health and Health Disparities, and in that course, they had been taught that race is never really a useful proxy and/or risk factor in healthcare, but other courses have reinforced the use of race clinically. So she wanted to discuss why race is so widely used, what's the evidence behind this practice, and what factors contribute to this disparity. So we met with the students and discussed our thoughts on race and medicine, and the students were happy. But this question continued to provoke me. Now, I mentioned the date because I think it's important to put this in the context of what was happening in our country at that time. Shortly after I received this email, just a few weeks later, we learned that Ahmaud Arbery had been shot to death while jogging in Georgia. And a few weeks after that, Breonna Taylor was shot to death. And then on May 25th, 2020, George Floyd was slowly asphyxiated by a police officer. And this came on a background of far too many deaths at the hands of police officers. And I have to bring this up to date with the most recent killings of the 10 individuals in Buffalo. And I bring this up in part because when I talk about race in medicine, I usually talk somewhat about the different types of racism, personal racism, institutional racism, and structural racism. And I have said that personal racism has not been as pervasive, perhaps, and has not had as great an effect as institutional and structural racism. But I think that we can see as we watch what is going on in our country that all three of these feed each other. So against this background, I began really looking at race in medicine and were we contributing somehow to disparities in health. So my question was, how does race show up in the curriculum? And since I'm a pathologist and this is our textbook, I looked in the textbook. I searched the electronic version of the book using terms like Caucasian and African, Hispanic, and what I found were more than 35 diseases for which some sort of disparity was associated with socially defined race, be it prevalence or prognosis. Now, let's put this in the context of what we're actually talking about. So here are some actual quotes from the 10th edition of Robbins' Basic Pathology relating African Americans and cardiac amyloidosis, carrier frequency of cystic fibrosis in Caucasians, cholesterol gallstones in Native Americans, and adenocarcinomas in whites and Asians. And I think let's first of all set aside the outdated terminology because that's easy enough to fix. Let's remember that when these sentences were written, they were written with the best of intentions. And for many of us, This is how we learned them, with the belief that these epidemiologic data would help us to come up with a broad yet focused differential diagnosis, to order and interpret appropriate lab tests, and to ultimately construct the optimal therapy for our patients. So these sentences were written with the best of intentions. But it's not enough to simply say, I have good intentions. We have to ask the question, are we causing harm? So are we causing harm? I think that we are, and I think there are three areas we need to look at. The first one is one that I call buzzword bingo. So we take very bright, very intelligent, eager medical students and trainees, and we teach them simple word associations. White, cystic fibrosis, black, sickle cell. And we reinforce this through clinical vignettes, multiple choice questions, board preparatory materials, and the board exams themselves. Let's take a look at some of these board prep materials. This comes from a website called crashingresident.com. This post was from 2015. There were a variety of different recommendations that the author made. One of them was be as racist as possible. And as your eyes skim over this, I think that you will see that these are associations that all of us have learned. We have inherited this information and taken it as part of our belief system, and it continues to be taught. Now, this is obviously not very scientific, and it's done somewhat sardonically and with irony. Let's look at something a little bit more scientific. We obviously can't look at the questions of the USMLE. Those are proprietary and protected. But we can do the next best thing. And so what these two researchers did was they looked at one of the most widely used test preparatory materials, UWorld, and queried the question bank, looking to see use of race and ethnicity. So there are more than 2,100 questions. And the authors went through and counted the number of questions that mentioned race or ethnicity, and they further categorized them as to whether the use was simply descriptive, so it had nothing to do with the question and wasn't important to getting the correct answer, or whether knowing that person's race or ethnicity was central to getting the correct answer. So let's focus here first on the category white/Caucasian. So this was about 86% of the total mentions, which is important to recognize the disproportionality of this because about 62% of the American population fits into this socially defined race based on the 2020 census. So we have an overrepresentation here. And about 93% of the time, the use was purely descriptive. It had nothing to do with the question, but about 7% of the time it was central. So perhaps cystic fibrosis or coronary artery disease, which was very strongly associated with this socially defined race in this material. So this is problematic as far as the overrepresentation in the question base. But I think even more problematic is if we look at the Native American category, where you can see that if a Native American is showing up in your vignette, it's not because that person was in a motor vehicle accident or brushed up against poison ivy. It is because that person is Native American. It is always central. And it's due to something like lactase deficiency, gallstones, diabetes. So you can see here that we are reinforcing this association with socially defined race and disease. So you may be asking yourself, well, you know, these are just the preclinical years, and surely as our students move through the wards and on into residency, they learn about the vast spectrum of health and disease, and they recognize that these racial and ethnic associations really aren't that strong. And I would just say there are things I learned 20 plus years ago at the University of Chicago that I did not learn were wrong until I really began doing a deep dive into the literature. So then the next question may be, well, are we causing patient harm, right? Because, you know, first, do no harm. And again, I would say, yeah, I think we could be. So say you have a young Navajo woman who presents at an acute care clinic. She's got right upper quadrant pain, and the attending thinks, Native American, gallstones, and doesn't think about acute appendicitis or an ectopic pregnancy, either of which can kill the patient. Now again, you may say, well, surely this doesn't happen in American medicine. We have algorithms, we have checks and balances. And I would point your eyes to another disease, cystic fibrosis. This is a vignette that's in the literature. The author recounts a childhood friend who was not diagnosed with cystic fibrosis until she was 8 years old, despite presenting multiple times with suggestive symptoms. And in fact, she was only diagnosed by a clinician who could not see the color of her skin, but saw the chest x-ray and said, who's the kid with cystic fibrosis? So again, I think we can be causing patient harm. And finally, as we come to look at this, I think we have to take an even broader view. Is there a way we are causing societal harm? Is there a way that we are elevating one population and pushing another one down, saying, bad genes, non-compliant, risky behavior? Are we setting up a hierarchy in socially defined race? So let us return to the diseases that are the disparities in Robbins. And as an aside, I will mention that what I've done with this is not just to compile a list, but to actually do a deep dive into each of these. And I've generated about an 85-page document with figures and references that is freely available and which I share with my medical students. More on this later. But in order to see the perniciousness of the racial associations in this textbook, I will redline for you the diseases that are associated with African descent, and in green you can see the diseases associated with European descent. So yes, I think that we are causing societal harm. Now, are we causing harm to our learners? Again, I think, yes, we are. So this is a quotation from Damon Tweedy's book, Black Man in a White Coat. Dr. Tweedy was actually a Duke medical student and is now on the faculty. We work together at Duke. He's in the Department of Psychiatry. And this is what he wrote about his experience as a medical student at Duke. It seemed that no matter the body part or organ affected, the lecturers would sound a familiar refrain. It's more common in blacks than in whites. Each time the demographics of a new disease came up in a lecture, my stomach twisted. I knew where this was heading. Seated in a sea of mostly white and Asian faces, I wondered how this information affected their views of black people, whether they already had biases against us, and whether any of this impacted the way they saw me. So we are causing harm. Let's now take a moment to talk about what we're talking about, race in medicine. What is race? So in modern biology, races are defined by two criteria: the amount of genetic variation within and between groups, and phylogenetic evidence of a unique lineage. In modern humans, there is no phylogenetic evidence of unique lineage, and we know that humans show more variability within so-called races than between them, right? But we're obviously not identical, despite the fact that we share 99.9% of our DNA, which still gives us about 3 million base pairs of wiggle room. And we know that we have geographically based genetic and physical differences. But let's think about what race is. Here is an example from 1795. Race is this social construct which is used in a social dominance hierarchy. So back over 200 years ago, we have these 5 races that were defined: white, Asian, Pacific Islander, Black, and American Indian. Let's leap to the present day and see here that we have the exact same categories in our U.S. Census Bureau. And I'd like to take a moment to look at these because not only are these ones that we see in our census, but they show up in the SEER data. So the data that we look at for variations in tumor incidence are associated with these socially defined races. So we have white, a person having origins in any of the original peoples of Europe, the Middle East, or North Africa. But how much? Because what happens if you have someone who is Black or African American, a person having origins in any of the Black racial groups of Africa? So if you are half white and half Black, what is it that determines who you are? How does this correlate with our genetic background? Furthermore, we have to keep in mind that Africa has more genetic diversity on that continent than the rest of the world, because that is where humans evolved. If we look at the category of American Indian or Alaska Native, this refers to people who originated in the original peoples of North, South, and Central America, but specifically has a cultural note. They have to maintain tribal affiliation or community attachment. So if someone who is American Indian leaves that tribe, they're suddenly no longer an American Indian. So this is part of the problem when we look at data based on these socially defined races. And if you look at Asian, just look at the vast number of countries and you think about the geographic spread of Asia, and we know that genetic variation increases over distance. And how can we say that anyone who fits into this category has more in common with someone else who's Asian than someone who isn't? And the same issue applies to Native Hawaiian or other Pacific Islander. Again, we have a vast geographic distance. So when we are thinking about race, we have to remember biological race does not exist in modern humans, but socially constructed and defined race do. And this is the arbitrary use of aspects of morphology, geography, culture, language, etc., in the service of a social dominance hierarchy. Racism is what created race, and that is why Dr. Graves calls his book Racism, Not Race. So let's take a look at this with a little bit more detail. We can see here, I think it's useful to refer to this book from epidemiology. There's a lot that we can learn from epidemiology as we think about race in medicine. This comes from the introduction by Merrill, and he points out that race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. Racial or ethnic variations in health-related states or events are explained primarily by exposure or vulnerability to behavioral, psychosocial, material, or environmental risk factors and resources. Now, we know this to be true, right? We spend a lot of time doing genome-wide association studies and looking at allele frequencies, but the real driver of health disparities, particularly in the United States, is going to be socially defined race, which is associated with all of these other factors. I'd also like to quote an article from the New England Journal of Medicine, which is focused on genomics, because again, we have to go to the science on this. And here's the thing to remember, this variation we talk about, we look different from our different continents, but the variation is continuous and it is not concordant with race. We have systematic variation according to the continent is very limited, and there's no evidence that what we care about in medical genetics corresponds to what we call races. So all of these papers that are coming out telling us this is important with this socially defined race and that's important in that socially defined race is very, very questionable. So let's look at geography. So when we think about race, it apparently is based on our geographic ancestry. So this is an article, is a figure from an article looking at the distribution of a variety of hemoglobinopathies. Now, as you all know, hemoglobinopathies are associated with malaria because they confer selective advantage for people who are heterozygotes. So as you look at this, you can see, first of all, thalassemia is covering an incredibly large area. We have sickle cell, which we usually think of in the United States as the African American disease, but clearly you can see it's also prevalent in Southern Europe, parts of the Middle East, and India. So we cannot make an association based on a continent or even a geopolitical boundary of a particular country. And I think this is really brought home when you look at Africa. So we can see, we know that we have malaria throughout Africa, but gosh, there's this area here where there are no hemoglobinopathies. Why is that? That's where the Sahara Desert is. No water, no mosquitoes, no selection pressure, no hemoglobinopathies. Now, the one issue with this map is that although we have this sort of static appearance, we know that with population admixture and immigration, which is occurring across the world, we have a global incidence of disease. So even if there is an evolutionary reason for a disease to be more common in a certain population, because of globalization, you can see any disease in any population. And this has to do as well with population admixture. So I'd like to share a little bit of ancestry information with you, looking at some socially defined races just in the United States, but we'll also look at Latin America. So what we consider to be African American, and based on our census data, it means having really any African ancestry, you can see that the amount of European contribution varies significantly depending on which area of the country you're talking about. So, for example, in West Virginia and in Washington State, more than 30% of that individual's genome could be European ancestry. This becomes even more complex when we look at Latin American ancestry, because we have a triad mixture of European, African, and Amerindian. And this is, again, going to vary depending on where in the country you're looking at people. So we cannot use this ethnicity of Hispanic as something that is particularly informative, because there's so much variation even just in our country. But let's look a little bit further. So this is genetic ancestry of Latin American populations, and it's showing in these various pie charts a contribution of Amerindian, European, and Sub-Saharan. And there clearly are differences in these four countries, Puerto Rico, Mexico, Colombia, and Peru, that are shown regarding the amount of these different contributions. So you may be thinking, well, let's focus now on ethnicity, because if we look at country of origin, we'll have something that's more homogeneous. But you should know by now that's also not going to work. Let's take a look at just one country, Colombia. So here you can see a map of Colombia. And if you look at the genetic ancestry of individuals in Medellin, which is an urban center, you'll see that the admixture that you see is mirrors very closely what you see in most of Colombia. But if you look in the neighboring state of Chocó, you can see that there's actually a much greater African contribution. Admixture depends upon history. There was a lot of plantation agriculture in Chocó, and they brought enslaved individuals to work there. So we can't even say something about Colombia, and we're trying to say something about all Latin Americans in the United States. So if race is not a biologically useful concept, why is race so prevalent in medicine? And I think a lot of it is historical, and a lot of it has to do with systemic racism. The historical component is, for example, if you look in the first edition of Robin's Pathologic Basis of Disease in 1974, we see an association of black and keloids. And that association remains all the way up to the 10th edition of Robin's, where we can see in Robin's Basic Pathology, it says, certain individuals seem to be predisposed to keloid formation, particularly those of African descent. Now, I'm working with the other editors to address race-based medicine, and so I wrote the editor of that chapter, and I said, I would remove this part. And the editor responded with a short email that said, but this is what it says in UpToDate. Keloids have been reported in 5 to 16% of individuals of Hispanic and African ancestry. Now, as I mentioned, I created this deep dive into the literature for each of these diseases for my medical students. So I had read UpToDate on keloids, and in fact, I had also read reference 5, as well as about 30 other references on keloids. Now, reference 5 is quite interesting. In addition to this reference to, actually they say 4.5 to 16% of individuals, they had this other statistic that really caught my eye. The risk of developing keloids is about 15 times higher in dark-skinned individuals compared with whites. Now, 15 times is a big number, so that's got to be statistically significant. We'll talk about clinical significance later. But the other reason why this number caught my eye is because I saw it in multiple places. In fact, I saw it in 4 other papers. And I believe that the first incidence is Brissett, because that's the first time I found this statistic. Let's see what Brissett had to say. Brissett says, in a review of 175 cases of keloids from various races, the authors found that keloids were 15 times more likely to occur in darker-skinned individuals. So let's actually pull that paper by Ahadi and Sivanatharah from 1969. And this is what they say. The relatively fair-skinned Chinese appear to be slightly more prone to keloids than the dark-skinned Indians and Malays. Now, I did the math, and I came to about a 2 to 3-fold increase. So the number is wrong, the arrow is in the wrong direction, and it has moved all the way through these additional publications. But that's not answering the editor's response, which was the 5 to 16%. So let's come back to that. Where did this 16% come from? So I went back again and again and again through multiple papers, and it all comes back to 1931. So in May 17th of 1931, a journal came out that was reporting the proceedings of a dermatologic meeting in Strasbourg. And at that meeting, Monsieur Lespin gave a talk on tattoos and keloids in the individuals from the Congo. And after he finished, as so often happens, someone leaped up to talk about his research, not apparently to actually ask a question. And Monsieur Staub said, You know, I've been in the Belgian Congo myself, and what I did was I looked at the workers who are in the mines, and I looked at 1,205 of them, and I counted them and I examined them to see if they had keloids, and what I found was 16% of them did. So that's where this 16% is coming from. So 90 years ago, someone in the Congo, in a time of colonial exploitation, examined 1,205 members of that community. Now, even if we wanted to say that this is valid, we could say it's valid for that population. We can't say all African ancestry. But there's something even more problematic, because at that exact same meeting, Monsieur Negli gave his presentation on his research looking at keloids in Swiss adults and children. And what Professor Negli found in Bern was that 13.3% of Swiss adults had keloids. So while you look at this, you know, the 15-fold increase certainly sounds statistically significant. The 13.3 to 16% is a little questionable. So why is it that only 16% has made it these 90 years? And I do cover this in a video that I made. I actually have done several videos based on these discrepancies between the socially defined races. So after I gave all this information to the editor, this is what we came up with for the next edition of Robbins. Keloid formation seems to be an individual predisposition. Now, this video that I made goes into a very lengthy discussion, about 20 minutes, going through the data, which I emailed then to the authors of Up to Date. They did change part of it, but another part of it retained this association with socially defined race. Dr. Graves and I had an article in New England Journal of Medicine in which we called them out again, saying, you know, it's still mentioned there. We mailed that to them. And now you can see that it has been improved. So before I brought this to their attention, here you see the statistic that is being used to reinforce keloids in African ancestry, and now it has been removed. But I will tell you, and this is something that as you look at race-based medicine and you do these deep dives, you're going to get pushback, right? So this article that Dr. Graves and I published in the New England Journal, someone wrote a letter to contest some of what we had said. There were fatal flaws in that letter, so it was not published. But the authors brought up these two papers. And this is what we find when we address race-based medicine is, but what about, right? So here are two studies that look at keloids based on race. So this first one looks at about 430 patients and finds a keloid incidence of about 7% in African Americans compared to 0.5% in whites. Okay, the odds ratio between these two socially defined races is 16.5. This other article, which is looking at many more patients, finds a very different incidence, 0.8% versus 0.1%, and an odds ratio of 7.1. So already this is telling you that something is amiss, and it probably has to do with how we define these groups. Because as we know, biological race doesn't exist. There are variations by region, right? And these studies don't actually describe how they determined what the socially defined race was of these individuals. Was it self-report? Was it someone looked at them? And it's actually even more interesting because this first study is from Canada. So I don't know how they defined African Americans. Were they actually from the United States? Was it African North Americans? I don't know. But the thing is that even if this were true, right, it doesn't apply to all African Americans because, again, Africa has more genetic diversity than any other continent. You cannot make these sweeping generalizations. So we're looking, right? We're using our eyes to see. So we're not just looking at this, let's look at problems in other textbooks. So we'd already worked through this for Robbins. I sent a link to one of my grand rounds to one of my former mentors, Lainey Friedman Ross at the University of Chicago, and she was captivated. She's not only a pediatrician, but also an ethicist. She said, we have to look at pediatrics because pediatrics is rife with race-based medicine. And the text we chose was the American Academy of Pediatrics textbook of pediatric care. And one of our goals in doing this was to look at a book which was produced by a society because they have a little bit more mobility in responsiveness. And we also wanted to address it because we knew that the third edition would be coming out soon. They hadn't started work on it yet. And we did something similar to what I did in Robbins, which was to search the ebook using terms associated with race and ethnicity. And we found more than 2,100 results, 806 of which were relevant for analysis. So we threw out things like black box warning and black widow spider. And when we condensed them down, there were about 235 statements or tables because they all mention multiple races and ethnicities in each one. And our first goal was to code them as problematic versus non-problematic. And that was fairly easy. It was really obvious this is problematic and this one is not. And then through that, we then worked to identify what are the themes of problematic usage with the goal that we could share this information for people who are revising textbooks, who are designing studies, who are thinking about race-based medicine. And we came up with a mnemonic, SCORISC, and I'll show you what that is. So here you can see what the mnemonic stands for, using race as a surrogate for social variables, conflating terminology, overgeneralizing, lacking clinical relevance, lacking inclusivity, promoting racial stereotypes, and contradicting race claims in the text. I'm going to go through this in a little bit of detail. You're, of course, welcome to read the paper. So using race as a surrogate for social variables, we provide for each of these categories questions that you can ask. And if the answer is yes, then the use of race is problematic. So the example here is they're talking about factors that can predict smoking, and they say that Alaskan Native and Native American ethnicity is predictive of smoking. That's probably going to be related more to socioeconomic status, cultural issues. It has nothing to do with a genetic background. Conflating terminology. To use the term Black, African American, and African descent, these terms are not interchangeable. They have different meanings. And so here we have a comparison of East Asian descent and Black infants. So that doesn't work. Overgeneralizing, this was something that we found very troubling, is a statement that referred to something that pediatricians need to be aware of, that Latinos might use as a folk medicine adult urine to treat conjunctivitis in children. So we actually couldn't find where this was a widely used practice, and certainly not something that was so common that it belonged in a textbook of this magnitude. Lacking clinical relevance, I'm going to talk more about that in a moment. This was fairly obvious because when you look at this, looking at birth weights, the standard deviations all overlap. And so why even mention that there's a difference between these various socially defined races? Lacking inclusivity, this is a big focus that I've been working on for the 11th edition of Robbins' Basic Pathology. Here, for example, they're talking about acrocyanosis, and they point out that this is blue color of the hands and feet when the rest of the body is pink. Well, that may be if you have a child who's got light pigmentation, but in darkly pigmented individuals, they won't be blue and pink. We have promoting racial stereotypes, so this was linking oppositional defiant disorder to a vignette with an African-American boy. This is very problematic. We discuss it in the paper. And then the easiest one is contradicting race claims. So on one page it says Native American children suffer most from Rocky Mountain spotted fever, and just a few short pages later it says, well, it mostly affects white people. So this paper has not yet come out in press, but we do have the online ahead of print. I don't even have the PDF for you. This is of the page proofs. But as soon as it came out of embargo, we emailed it to relevant individuals for the American Academy of Pediatrics. And I'd like to say that we had an impact. About 3 months after that, this news release came out from the American Academy of Pediatrics, noting that it is putting all its guidance under the microscope to eliminate race-based medicine and resulting health disparities, and that they are going to scrutinize their entire catalog, including here prominently textbooks. And I think the microscope may be a nod to pathology. So we are having an impact in what we're doing, and it is important. And there are problems that come up when we don't want to just throw out all of the associations with geographic ancestry when we come up with guidelines. The issue that's problematic is using socially defined race. Now, I'd like to return to the question of statistical significance and clinical significance. This is something that I personally find very challenging and is hard to tease out. So I'm going to share some numbers with you, and this is something that we can talk about because I know that people feel very passionate about this. So this is the statistic about lupus, that about 1 in 1,000 European Americans and about 4 in 1,000 African Americans. That comes from UpToDate. the numbers that were provided in UpToDate were these: 164 per 100,000 European Americans and 406 per 100,000 African Americans. But this comes from a study that was done in Pennsylvania and California, so we've ignored this part over here, the 203 and the 694, and we have picked these. So to make it simpler, I've just said 1 to 1,000 and 4 to 1,000. Now, in order to get an idea of why this is important, right? Because it's not like we're going to gather 1,000 European Americans and 1,000 African Americans, say 4 of you have lupus and 1 of you has lupus, and we're going to go look and see who it is, right? What we actually do is we have a patient who has symptoms and we want to determine if that patient has lupus. So let's imagine a laboratory test with 95% sensitivity and specificity for lupus. Let's look at the positive predictive value. And by the way, this is in European American women and African American women. So you can see that if the prevalence were 1 in 100 versus 4 in 100, this one test, the positive predictive value in a European American woman would be 17%. And if it were positive in an African American woman, you'd have a 44% chance that it was correct. But if we move it to 1 in 1,000 versus 4 in 1,000, we now drop to 2% and 7%. So the test is in many ways, as we look at this, become meaningless, right? Now, of course, this isn't how we diagnose people. We don't have our one test. We use our clinical acumen. We do a physical exam. We do imaging. We take a biopsy, which, as you all know, pathology, that's the gold standard. But even when we look at this association, right, and we look at this positive predictive value, when we think about the role of race in this, this is the sentence that will be in the textbook. Lupus, it's more common in African Americans. And my question for you, and we're going to return to this, is how does this serve, right? We're teaching medical students to make this association. And my question for you is, based on this, does this really serve patients? Does this serve society? And I'll come back to that in a moment. So let's look at something else, right? So let's look at multiple myeloma, which is even less common. 6 in 100,000 European Americans, 12 in 100,000 African Americans. And using our same 95% sensitive specific test, sorry, that should say for multiple myeloma, we now have a positive predictive value of 0.1% and 0.2%. Why? We don't have a single test that we use, right? We look at multiple lytic lesions. We do a biopsy. All of this comes together. So let's see how we bring it together. This is from a paper that was looking at laboratory tests for multiple myeloma. And you can see here SPEP alone, not particularly sensitive or specific. Serum-free light chains, pretty good. But if you put them together, 100% and 99%, right? And if you add into that a biopsy, lytic lesions, you're going to make your diagnosis, right? So it all comes together. It's a very complex story, but that's not what it says in the textbook. It says multiple myeloma, more common in African Americans. Yes, it's twice as common. It's still incredibly rare. So there we have it, multiple myeloma, more common in African Americans. So this brings me to something that was presented to Duke School of Medicine by Shaniqua Collier. And she was talking to medical students, and she had a poll, and she put this question up. And I think we have to ask this question. So she wanted to know, do you agree with the following statement? Any small benefit of race-based medicine, because we're looking at this and it's looking like race-based medicine, saying it's more common in this socially defined race than that socially defined race. Maybe there is a subtle, very small benefit. I'm not saying there is, but maybe there is. Does any small benefit outweigh any potential harm caused by a history of racism? And I think we have to ask that because we know that we have systemic racism, we have institutional racism, and we have individual racism. And are we feeding that by making socially defined race-based medicine? So I ask you that. So as we're looking at this, the question is, well, what else is there to see, right? What else are we looking at? So I'm going to put up an image for you. This comes from the skin chapter of Robbins' Basic Pathology. And you'll immediately, if you're, since you're a pathologist, you'll be trying to figure out exactly what these lesions are, and maybe not looking at the background. But if you do, you will notice that all of these images are in lightly pigmented skin. And if you've done any work looking for images online, in journal articles, etc., you'll find that almost all of them are shown in lightly pigmented skin. Now, in the 10th edition, we do have 4 images of darker skin. You can see them here, and you can probably recognize them. What we're doing for the 11th edition, and I'm very proud of this initiative, is that we are showing skin lesions in multiple skin types. So we have here basal cell carcinoma, which has a very different appearance in darkly pigmented skin. This could mimic a melanoma, for example, erythema multiforme. We have seborrheic keratosis and what is more commonly seen in individuals' darkly pigmented skin, etc. And this is particularly relevant here when we look at psoriasis. So let's think of what we're seeing, but how we describe what we see. So this is what it said in the 10th edition. The typical lesion is a well-demarcated pink to salmon-colored plaque covered with loosely adherent silver-white scale. And if you look at this image, you can say, why, yes, it is. But not if you have darkly pigmented skin. So here we can see the clinical image that we'll be including in the 11th edition. And we've changed the wording as well. I had a dermatologist read over this and help me to wordsmith this. And now we add in patients with darker skin types, plaques range from salmon-colored to hyperpigmented and demonstrate gray scale, which reflects what we see in the image. So looking at the clinical images is very important. What else is there for us to see? And the important thing is that we so often see, but we're not looking. And we don't look, we don't see clearly. So here is a compilation of images from the 10th edition of Robbins Basic Pathology. And again, depending on your socially defined race, you may see absolutely nothing at all problematic about this image. Maybe like, oh yes, look at this. These are good cartoons showing a variety of pathologies. But for some of our students, attendings, residents, fellows, etc., seeing this image is a reminder of what is important, similar to the 86% of questions in UWorld that focus on white and Caucasians. Okay, so what we're doing for the next edition is to remove skin color. And I think moving forward, as you can see some of these, we've removed the genitalia as well, because it's really often not relevant. And so we want to make this so that anyone who looks at this can see these images and focus on what we're actually trying to teach, not some sort of hidden curriculum of this is important in white people. So the question I then raise for you is, how do we see clearly? And as I mentioned, the first thing we have to do is we have to look. And I've been very fortunate in that the talks that I have given have been very well received. I get great feedback. I hear from editors of books who say, we're going to use this when we do the revision of our textbook because we need to think about this. I've heard this from residents and medical students and faculty that, you know, we haven't thought about this before. How do we address this? We've always just assumed that race-based medicine, which we all learned, right? We've learned this for generations. We've all learned that it's true. So how do we see clearly? If looking at this talk and what I've presented still doesn't resonate with you and you still say, you know, I don't know if I agree with this, I'm going to give you a couple of recommendations. So I think these 3 papers are a great place to start. 2 of them are focused on genomics because I think we have to look at the evolutionary background because that is where the truth lies, right? We're making assumptions on small changes that reflect the color of the skin, the shape of the eye, the texture of the hair. We need to really think about what is going on genetically. This 3rd paper here with the senior author is Jennifer Tsai is a really brilliant emergency medicine resident at Yale, whom I met when I gave grand rounds there. I think she reminds us that because part of the fear is we're going to get rid of all this information and some of it may be useful. We're not saying discard race-based, right? We're not saying get rid of race. We're saying use race-conscious. Be aware of the contribution that socially defined race brings to health disparities and use that to act wisely. And as you may be trying to see more clearly, what is absolutely critical is to bring in as many people as you can from different backgrounds. And we're talking here, you know, in this talk, I'm talking about race and ethnicity, but also from different gender identities, sexual orientations, because it is so easy to see our world with our eyes from our perspective. And it's really important to bring in people from different perspectives and to give them the power and the space and the courage to speak up. And you have to be able to listen with grace and humility. Now, when you have begun to see, right, the question is, what do you do with that? And I don't know whether the people with whom I've worked, who I thought had seen, if their lack of action is because they then chose not to see, maybe they didn't see, maybe seeing was too hard, and because this work is incredibly hard, right? So the amount of research into disproving race-based medicine to really look at and provide context as it's necessary is immense. And it is so much easier to just say, it has always been such, right? But we cannot do that, and at least I cannot. And so for me, the answer is I cannot unsee. And so what my work has been, I've created a website called Pathology Central, pathologycentral.org, in which I have a series of videos, predominantly on pathology education, but also on race and medicine. And I hope to expand that once we're finished with this edition of Robbins, to actually do a video for each of those diseases to make it easier for educators, students to understand where this disparity comes from. So here you can see a catalog of some of the videos. I do this on my own time. I fund this myself. And the goal is to share this as widely as possible, because while Dr. Graves and I have been giving many, many talks, we obviously can't talk to everyone. So there are videos that can be shared freely via YouTube. So I'd like to finish just by giving you a list of my references. I'm happy to share PDFs of these as well. And just to finish with another visual image for you. So some of you who look at this will see two faces looking at each other. Some of you will see a vase. And I think it is important for us to be able to see both in order to train our eyes to see all that is around us and not to be captivated by optical illusions. So with that, I will thank you for your time. I look forward to taking your questions in person at the APC meeting. So thank you very much.